Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can find our previous episodes on Apple Podcast, Spotify, Google Podcast, Stitcher Radio, and on your favorite podcast app. Today, we're trying out a new type of episode, so we'd love to hear what you think. We've invited a clinical expert to discuss how she evaluates and treats patients with a specific condition. In today's episode, we've invited Dr. Maureen Dubreuil to discuss her favorite disease, spondyloarthritis. Dr. Dubreuil is a rheumatologist at Boston University School of Medicine, where her research focuses on comorbidities and pharmacoepidemiology of spondyloarthritis. She serves as education chair and board member for the Spondylitis Research and Treatment Network. She's a medical advisor for the Spondylitis Association of America and is a member of the Assessment of Spondyloarthritis International Society. She's really a fantastic teacher and has really insightful tips on the diagnosis and management of spondyloarthritis. Hope you enjoy the show. Maureen, welcome to our show.
Thank you so much for having me.
So we're going to be discussing today a little bit about axial spondyloarthritis. And, you have been treating patients with axial spondyloarthritis and conducting research for a while. So I was hoping to get some of your tips about how to recognize these patients and manage them over time. So, I think one of the most important things is sort of the clinical presentation. So how is it that people with axial spondyloarthritis typically present?
Yeah, so thank you so much for that question. Most commonly, people find their way to a rheumatologist or their primary care physician because they have chronic back pain or back stiffness. And oftentimes this back pain or stiffness has been going on for quite some time. So we know that on average, it takes 6 to 8 years for people to ultimately have a diagnosis of axial spondyloarthritis. Yeah, so quite some time. Now, on the other hand, there are people who make their way to their physician relatively early in their course. And so we can kind of recognize people first when their back pain or stiffness develops into a chronic condition. But occasionally we do identify these people later in their course.
Okay. And so back pain is so common. Sometimes I get back pain, and I believe that complaints of back pain is one of the most common presentations of people when they go to their primary care doctors. So how do you make the distinction of sort of the typical run-of-the-mill back pain that many of us have from the back pain of somebody that has ankylosing spondylitis or axial spondyloarthritis?
Yeah, this is a big challenge because about 20% of adults in the United States do have chronic back pain. And so distilling down from that big 20% of our population to the around 1% of people who have axial spondyloarthritis is an important task. As primary care physicians could tell you, there are a lot of people who come in because of chronic back pain, and most of them don't have axial spondyloarthritis. So we historically have used the inflammatory back pain pattern to narrow down the population of people with chronic back pain to those who should go on to have a further workup for axial spondyloarthritis. Now, in recent work, we know that this concept of inflammatory back pain doesn't perform as well as we initially hoped. So although we do still use these questions, they're going a bit out of favor, and it may be in, another 5 or 10 years, we have better ways of focusing our evaluation for specific people.
So what are those questions that are thought to determine inflammatory back pain?
So they're similar to the inflammatory joint pain concept that we know from evaluating people for rheumatoid arthritis or other forms of inflammatory arthritis, with one important addition. So the addition is the age criterion. And in various sets of criteria, it can be age 40 or age 45. The chronic back pain begins before that age. And then we think about the other inflammatory features being pain that becomes better or improves with movement or exercise, and pain that becomes worse with rest. So the very common complaint I hear from my patients with axial spondyloarthritis that's not yet treated is that they wake up in the middle of the night because their back is so tight and stiff that they can no longer sleep. They get up, they move around, sometimes take medications before they can go back to sleep.
So yeah, it sounds that history is a little bit different than the typical mechanical back pain that, I even sometimes get is when I'm doing activities, when I'm bending over, it hurts more. And if I lie and rest, the symptoms go away. That's great. And so the nighttime waking up with pain seems to be more indicative of an inflammatory back pain rather than mechanical. That's great. And at which point should primary care doctors who are taking care of, this 20% of patients with back pain, what point should they think about either doing additional workup or referring their patients to a rheumatologist for concern about axial spondyloarthritis?
Well, you have identified a very hot topic in research right now, and it's a subject of a research project we're doing through the Spartan group, which hasn't been finalized. But what we are likely to recommend is that young adults, which I'll loosely characterize as people under the age of 45 with chronic back pain, and almost anything else that increases the probability of an axial spondyloarthritis diagnosis, those folks should be referred. So it does include this inflammatory pattern of pain, but also other features that suggest axial spondyloarthritis. And so that's things like the presence of skin or nail psoriasis, inflammatory bowel disease, or uveitis, which is, for people that may not be familiar with that term, is inflammation of the middle layer of the eye. Most commonly, the anterior uvea is inflamed in axial spondyloarthritis.
Got it. Okay. So chronic back pain with inflammatory features and perhaps any of these additional features that may raise the suspicion for axial spondyloarthritis. Maybe those patients should be referred to a rheumatologist for further evaluation. So when you get these patients into your clinic, how do you approach their diagnosis? What is it that you ask them, and what is it that you want to try to examine on the physical exam to try to sort out whether or not these patients may have something like axial spondyloarthritis?
So I am a rheumatologist, and I begin with a detailed history, as many of us do, asking questions about these inflammatory back pain features. And, as people kind of accumulate more features of inflammatory back pain, in my mind, that increases probability. I also ask about peripheral joint arthritis or enthesitis, meaning inflammation at the site where a tendon or ligament attaches to bone. And the most common site for enthesitis is the Achilles tendon in the heel. So that's also a fairly common condition, right? Many people have Achilles tendonitis due to mechanical causes.
Yeah, I have a little bit of that from running.
Exactly.
Hopefully not indicative of axial spondyloarthritis.
Exactly. But, you can think the combination of chronic back pain and Achilles tendonitis, that's still pretty common. So, we keep probing for more potential features. So it includes the personal history of those three conditions I mentioned, psoriasis, inflammatory bowel disease or uveitis, but also includes a family history of axial spondyloarthritis or associated conditions.
Yeah. Do you focus at all about if they take NSAIDs, whether NSAIDs has a very beneficial effect? Is that something that is typically seen in these patients?
Yes, that's absolutely correct that about 80% of people who have axial spondyloarthritis feel better after they take NSAIDs. And the dosage is a little tricky. So this doesn't mean taking, a single pill of over-the-counter ibuprofen, but it means what we consider to be really anti-inflammatory doses. So higher doses of ibuprofen, naproxen, or any of the others. This can be in contrast to people with mechanical causes of back pain, where only 10 to 15% of them feel better with an NSAID.
Oh, fantastic. Okay. So good question to ask. What about the physical exam? Is there anything in the physical exam that heightens your suspicion for axial spondyloarthritis?
Yes, so it's a great question. And I think something we as educators could really focus on a little bit more. Generally, there are a fair number of trainees who end their training program without knowing how to do a great musculoskeletal exam. And then the exam of the sacroiliac joints is even further neglected. So learning how to examine the SI joints is one of the most important things in being able to recognize axial spondyloarthritis. So how do we do that? First, we ask people where their pain is. And for involvement of the sacroiliac joints, people tend to point to their buttocks, their upper buttocks, and no higher than the waist. So that may be an important distinguishing feature between other causes of chronic back pain, which are most commonly degenerative disc disease involving the lumbar spine. That's above the waist most of the time.
That's a good tip.
Yeah. If people are unable to localize it or they point kind of vaguely to their waist, which is nearly everyone, we then go on to do a physical exam to help define the pain generating site. And the first thing we'll do is palpate over the SI joints. So those are linear structures over the upper to mid buttocks, right? And if there's pain with palpation, that supports the presence of sacroiliitis.
But yeah, I understand that, other people with mechanical back pain may also be tender at the SI joint. Is that right?
Yes, that's absolutely true. And there are, mechanical causes of sacroiliac joint pain. In particular, if people have lumbar disc disease, then there's kind of excessive movement at the SI joint, and people get osteoarthritis there too.
Got it.
So you're right. That's not the most specific exam. And we then go on to do others. So one is the Faber test, which is movement of the hip. So Faber stands for flexion, abduction, and external rotation. And when you move the hip in that movement and it causes pain on the same side, SI joint or buttock, that's a positive Faber test. And that supports sacroiliitis. We can also compress the SI joint and apply torsional forces using a Genslen maneuver and others to support that diagnosis too.
Great. Do you ever measure back flexion? Is that helpful?
So it's a great question. It is helpful in identifying some pathology within the spine, but it doesn't point to a specific cause. So people with degenerative disc disease in the lumbar spine also have reduced spinal flexion, which we typically measure with a Schober, modified Schober test.
Got it. Okay. And aside from looking at the sacroiliac joints, are there any other maneuvers or tests that you do to assess the rest of the spine?
Yes. So it is important to recognize that although axial spondyloarthritis classically starts in the SI joints or involves the SI joints by definition, people can have inflammation at any level of the spine, all the way from their occiput to their tailbone. So we also palpate the posterior spinous processes, and we do measurements of mobility at all the spinal levels to assess for disease of those sites. So we measure cervical spine mobility with rotation and lateral bending. We measure thoracic spine mobility with a chest expansion test.
And how do you use, your history and your physical exam to assess who needs further workup? Does everybody with, this history of inflammatory back pain get imaging, or is it the ones that also have some physical exam findings, or is it sort of your clinical judgment about who may or may not have inflammatory back disease?
Right. So thank you for this question. I would say there is not a lot of data about precisely which features to require in order to go on for further evaluation. Now, we generally have a pretty low threshold for evaluating other causes of low back pain with additional imaging. So most commonly, a primary care physician might obtain x-rays of the lumbar spine, for example. So in evaluating the cause of back pain in my patients, I will often add the AP pelvis x-ray to that x-ray series I'm already performing in the lumbar spine to look for degenerative disc disease, spondylolisthesis, etc.
Got it. So just to make it clear, if they don't have any previous imaging, do you get both a lumbar spine and a pelvis, or do you just focus on the pelvis?
It's individualized for the patient, and oftentimes if people can localize their pain specifically to the SI joints, we can avert the need for lumbar spine imaging, but that's a minority of patients, I would say. And for most patients I see, the pain is more generalized around the waist area, and therefore we're looking a little bit more broadly.
Okay, that's great. And so, if you find degenerative disc disease, for instance, of the lumbar spine, does that suggest that the patient does not have axial spondyloarthritis, or do you think, do some patients can have both?
So if a patient is found to have degenerative disc disease in the lumbar spine, it doesn't rule out the possibility of also having concurrent axial spondyloarthritis. We know that degenerative disc disease is also quite common. So in my practice, in many cases, we are continuing to pursue the diagnosis of axial spondyloarthritis, even if we find some disc disease.
Got it. And the benefit of a pelvis film rather than a dedicated SI joint, is that because you get images of the hips as well?
The view that I order and that has been evaluated in assessment of sacroiliac joint changes is an AP pelvis film. Now, in some healthcare systems, this may be called an SI joint X-ray. But what has been studied is whether oblique views of the SI joint improve the sensitivity of that study. And it has been found that oblique views don't help too much. So we're able to use a single AP pelvis X-ray. Now, this also tends to capture the upper portion of the hip joints, so we can evaluate that, but it tends to be kind of incomplete for the hips. So if I have concern, I go ahead and order dedicated hip films as well.
Okay, great. Certainly in some cases, when you have, for instance, ankylosis or erosions on plain films of the sacroiliac joints with a proper history, that's probably pretty diagnostic of somebody with axial spondyloarthritis. What about the cases where those films are normal or don't clearly identify any specific abnormality that suggests axial spondyloarthritis?
Yeah, so that's where the field has really undergone a revolution in the last 2 decades. Where when I was in medical school many, many years ago, number not to be stated, we were taught about ankylosing spondylitis as a disease in which there were definitive changes on X-ray. What has happened in the last couple decades is recognition that the majority of people with axial spondyloarthritis do not have X-ray changes. They have changes only visible on MRI. And the benefit of MRI is that we can see inflammation of bone and inflammation of other soft tissue structures. So when a person has a normal AP pelvis X-ray, if they still have a moderate or high probability of having axial spondyloarthritis, I go on to order an MRI of the pelvis. And I'll go ahead and just talk about the sequences that are most helpful in identifying those inflammatory changes. So the first is a T1 sequence with axial and semicoronal views, and then a T2 fat suppressed with those same orientations. And we look at these paired side by side. The T1 views give us evidence of structural changes. So we can see erosions on there. We can see sclerosis of the bone. And then the T2 fat suppressed images show us the inflammation. So as we go through, we see erosions paired with inflammatory bone marrow edema changes. Those are classic for axial spondyloarthritis, what we term now the non-radiographic form, meaning they didn't have changes on the X-ray.
When you're reading things, they often have these two buckets of non-radiographic axial spondyloarthritis and just axial spondyloarthritis. Do you think that they are like two distinct conditions, or is it sort of a gradient of, somebody with either earlier or milder disease in the non-radiographic camp, and then somebody with more aggressive or more long-standing disease in the radiographic camp?
This is another exciting and ongoing area of research where we know most people do not have X-ray changes throughout their whole life, right?
Wow.
But there is a proportion, it's estimated somewhere between 10 and 50% of people do go on to develop permanent X-ray changes affecting the SI joint and elsewhere in the spine. So, the burden of disease is the same regardless of whether a person has X-ray changes or not. There's, equal quality of life deficit, et cetera. We know people are equally likely to respond to therapies regardless of whether they have X-ray changes. So we really have a need to identify better biomarkers of what predicts X-ray changes over time, because those X-rays are bony changes, permanent bony syndesmophytes that limit mobility and limit function later. So hopefully in the coming years, not too many years, we'll be able to better predict who's going to change from just inflammation to go on to develop bony damage.
Got it. And is that something that can be prevented with appropriate medications early on, or are there still some patients that tend to progress and develop bony erosions versus other patients that even with or without therapy may not necessarily progress?
Well, so we do know some risk factors for what we call radiographic progression, development of permanent bony damage, include being a male, being HLA-B27 positive. So that's the gene that confers most of the heritability for axial spondyloarthritis. We also know smokers are more likely to develop permanent damage, and those with inflammation by CRP elevation. So we do know some of the predictors. Now, in terms of preventing bony damage, we don't have as much data. What's just emerged in recent years is some data suggesting that TNF inhibitors prevent long-term radiographic progression. And that's because it seems to take a long time. Firstly, people need to be started on treatment during a period of their disease when they have inflammation, so pretty early in the process. And secondly, it seems they need to be on treatment for at least 4 years or longer before we can detect a difference in progression.
Wow. Okay. So it sounds like at least, TNF inhibitors may prevent or delay progression of these erosions. That's great. So, I was thinking, are there other diseases that you sort of categorize in a different way, whether you find something on x-rays or not? I was thinking about gout, like if you're able to see tophus with the naked eye, that's tophaceous gout. And if you require a microscope, then, that's a different type of gout. Does that make sense in terms of axial spondyloarthritis, that it's just a more detailed, that getting MRIs is just a more detailed and better way of detecting these patients earlier rather than detecting, people that have a different disease?
I think that's a great analogy, and I totally agree with that we've just become better at identifying these people through the use of MRI, but MRI is still not perfect, right? Because we still have some proportion of people that don't get better with our existing therapies, or some proportion of people that just never progress. So we still have some work to do in terms of optimizing our imaging modalities and really understanding predictors of progression.
Yeah. And I guess the other complicating factor is, I always thought that if you have MRI changes, then that's pretty diagnostic of, sacroiliitis, of axial spondyloarthritis. But it seems like people with chronic back pain or people, even healthy controls, may also have some changes at the SI joints. And so does it require a proficient radiologist to try to distinguish the two? Or are there some features that, can only be seen in axial spondyloarthritis and then are never seen in somebody that has more mechanical back pain?
That is a very important question. And, I was excited to hear you're a runner. I'm a runner as well, and occasionally in this decade of life, after running, it will exacerbate my back pain. Now, what we know is that in imaging studies of runners and other athletes, the MRIs of those people also show bone marrow edema. And the same is true for women who are postpartum. They tend to have areas of bone marrow edema. So we know that mechanical stresses around the SI joint can cause bone marrow edema, and that the edema alone doesn't indicate the presence of a primary inflammatory cause. So this MRI, the MRI result needs to be considered in the context of the whole clinical picture, which includes the history, the exam, the inflammatory markers, genetic studies, et cetera.
Got it. You just mentioned it. We didn't address, specifically about blood work. So inflammatory markers are sometimes elevated or usually elevated in these patients?
CRP historically has been elevated in most people with ankylosing spondylitis, the form with X-ray changes. The proportion with CRP elevation is a little bit lower when we look at all comers with axial spondyloarthritis, but for most people it is still elevated. And then the gene, HLA-B27, this is a gene that codes for the MHC class 1 molecule. And I hate to go back to like immunology 101, but this molecule presents peptides on the surface of immune cells, presents it to activate other lymphocytes and immune inflammation processes. So when this gene is present, people are at an increased risk of having axial spondyloarthritis among those with chronic back pain.
Got it. Okay. Right. So, sometimes that gene gets checked and then people get sent over to rheumatology, sometimes even in the absence of back pain. It was checked for some other reason. It seems to me that most people with HLA-B27 do not develop axial spondyloarthritis, and it's just a minority. But then of people that have axial spondyloarthritis, many of them do carry this gene. Is that right?
That's exactly right. So HLA-B27 gene, it's actually several alleles that are risk alleles. It's present in 10% of US Caucasians. So it's present in many more people than have axial spondyloarthritis. In fact, 1 out of 10 people who are HLA-B27 will have disease, right?
Okay.
And we don't have more specific data on the number of copies a person carries or specific combinations of risk alleles. But you are absolutely right. Most people with HLA-B27 don't have axial SPA. One caveat to keep in mind is that HLA-B27 is also associated with uveitis, independent of spinal involvement or other joint involvement. It may be checked in a person that has uveitis, in which case that helps to determine therapy for those people. And those folks should also have an evaluation by a rheumatologist for the presence of spine involvement or other joint involvement.
It always puzzles me when, I see a gene that seems to predispose people to disease that is not great, whether it's axial spondyloarthritis, uveitis, psoriasis, inflammatory bowel disease. And I always think about, like sickle cell for malaria, that it confers some protection against malaria. Is there any benefit of carrying the HLA-B27 gene that has been discovered, and to try to understand why it's so common and yet the only things that it seems to confer is bad things?
Yeah, that's a great question. I don't have a evidence-based answer for that, but I suspect that it did prefer some protective advantage to, ancestors of those who are HLA-B27 positive now.
Right. As you mentioned, perhaps it was better at presenting certain peptides associated with some infections.
Yes, I'm going to have to beg for a pause on this question, and I could get back to you. I believe there is some evidence for that I haven't reviewed recently.
Okay. Yeah, I also have no idea. So just speculating. It sounds to me, based on what we've discussed so far, is that the diagnosis of axial spondyloarthritis is similar to many of our other diagnoses, is that it's not just one item that will cinch the diagnosis. It's a little bit of everything. It's the history, it's the physical exam, it's the blood work, and it's the imaging studies. And it's sort of your clinical gestalt, whether or not somebody has axial spondyloarthritis or something else. So having arrived at a diagnosis, how do you typically manage these patients?
This is a tough diagnosis for many patients to receive at first, because oftentimes these are young people. At times, some people are even in their teens when this develops. So many young adults have a hard time with this diagnosis. And so the first thing is providing education around what the disease may entail in terms of involvement outside of the spine and what the prognosis is likely to be, and then what the therapies are. I'll go ahead and maybe start speaking about the initial therapy. And physical therapy is the foundation of treatment for spondyloarthritis. So that's something we can get started even when an individual is kind of grappling with a new diagnosis, because physical therapy is a treatment for nearly every form of back pain. So I'll try to refer to a therapist that has some knowledge or awareness of axial spondyloarthritis and recommend both strengthening, but also flexibility and mobility focus. So the most important exercises for people with axial spondyloarthritis are spinal extensions at all levels of the spine. And so physical therapists can guide people through those initial exercises and form a home exercise program for each person to carry out for the rest of their lives, ideally.
Great. So physical therapy, I love that, you view that as the backbone of therapy.
No pun intended, right?
I love it. Great. Physical therapy. And that's easy to recommend for anybody, right? Even people with or without inflammatory features, physical therapy can certainly help alleviate some of the symptoms. What else? Do you just exclusively do physical therapy, or do you add medications early on in the diagnosis?
Yes, I do just want to make one caveat to the recommendation for physical therapy. Now, I was involved in some focus groups previously, and although it seems like a small ask for patients, it's really a big burden for some people to get to physical therapy once a week because it involves, time off work, which sometimes is not paid. So there are people who really can't get into formal physical therapy, and they can still be involved in a home exercise program. So there is a UK-based organization called NASS, National Axial Spondyloarthritis Society, and they have a series of videos that patients can use to learn the specific exercises.
Fantastic. So we can certainly have that on our website, acronair.org. And for anybody listening, you can just go to our website and we'll have links to these resources that you can check out.
Yeah, I highly recommend it. The other component is, of course, medication. And the first line medication, as we discussed previously, it's NSAIDs, so nonsteroidal anti-inflammatory drugs, which are typically oral at anti-inflammatory doses. So these are over-the-counter or general sales in the UK, and oftentimes people will arrive in my office having already tried one or two or more. So I first go through the recommended dosing with folks. If they've tried one, we go on to try a second one at an anti-inflammatory dose for at least 2 weeks. Many people respond to this. So in a trial against infliximab, which is a TNF inhibitor, around a third of patients actually went into remission with NSAIDs.
Amazing. Trusty old NSAIDs. So in this case, you're saying that it doesn't just cover up the pain, it actually helps decrease the inflammation at the SI joint?
So we have seen reductions in CRP and in bone marrow edema on MRI, but we don't know whether these meds, any meds really, are truly disease modifying.
Oh.
Right. Like we think of for rheumatoid arthritis and preventing erosions, we don't have data to support any class of meds being disease modifying for axial spondyloarthritis.
Interesting.
In that definition.
Okay. But is your suspicion that, things like TNF inhibitor do in fact modify disease?
I believe so, but it's based on very little evidence after only long-term use. So we need more to really say.
Okay. So you do the NSAID shuffle. If they didn't respond to ibuprofen, you put them on naproxen or things like that. It's awesome to hear that about a third of patients can actually achieve remission with one of these things. How about those people that have tried 2 or 3 or several NSAIDs and they continue having symptoms? What do you do then?
So this is a point of frustration for many patients because after NSAIDs, there are no recommended oral medications as the next line therapy for axial spondyloarthritis. So after NSAIDs, if NSAIDs don't work, we recommend going on to a TNF inhibitor medication. And any of the 5 in that class are recommended for treatment of axial spondyloarthritis, with a couple of specific recommendations for people that have inflammatory bowel disease or uveitis, where they'd be recommended to have something other than etanercept. So one of the other 4, either monoclonal antibody or infliximab.
Great. And you mentioned that there are no oral agents, I guess, first line approved. I hear it from so many patients that, they'd love to get better, but for whatever reason, they don't want to do biologics. They don't want to do any injectable drugs. Are there other second line agents that can be used for axial spondyloarthritis?
So historically, sulfasalazine was used fairly commonly. When I was part of the ACR guidelines panel reviewing this data in 2018, so now 4 years ago, there was not sufficient data for sulfasalazine to garner a recommendation. This will likely be reviewed with an upcoming iteration of the guidelines, but for right now, there is not an additional oral therapy that's recommended.
And then for other biologics, if somebody is on one of the TNF inhibitors, if they don't respond or fail after a while, do you switch them to a second agent, TNF agent, or do you try something else?
So there is the option to try a second TNF inhibitor, but the general recommendation is to consider an IL-17 inhibitor if a TNF did not work. And so there are currently 2 IL-17 inhibitors on the market in the United States, secukinumab and ixekizumab. Clinicians can choose either one of those.
Okay. And how about the IL-12/23s?
Yeah, it's a great question that I get asked a lot. At present, there's not sufficient data that IL-12 or 23 inhibitors work for axial spondyloarthritis. And the one that's received the most study is ustekinumab. Now, there was a perplexing and intriguing study that was presented at ACR last year of guselkumab in psoriatic arthritis with axial involvement, and that looked very promising. It seemed to have people had good improvement with guselkumab. So we may have further information in the coming years about specific disease phenotypes or characteristics that do respond to an IL-12 or 23 inhibitor.
Great. How about the JAK inhibitors?
JAK inhibitors are the newest kid on the block and a pretty exciting option, particularly for people who want to stick with an oral medication and people that don't have risk factors for thrombotic side effects. So JAK inhibitors as a class now have this FDA black box warning about thrombotic side effects, so myocardial infarction and cerebrovascular accident and deep venous thrombosis, etc. So these are not really an option for patients that have risk factors for those thrombotic complications, but for other healthy patients, we can use JAK inhibitors as potentially as a therapy after NSAIDs, kind of depending on what the next guidelines come out with. They seem to have a similar efficacy for patients, so around 50% of people with axial spondyloarthritis have improvement on TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. So they work about the same. Yep.
Yeah, and I guess it's similar to other conditions is that you never know which patient is going to respond to which drug. So sometimes if you're one of the unlucky 50% that fail one, you just have to sort of do trial and error until you find something that works.
Yeah, that's a really frustrating part, I think, of being a rheumatologist in general, but specifically with axial spondyloarthritis, is we don't have good biomarkers or other ways of predicting response. I agree with that entirely.
Great. So we spoke a little bit about physical therapy, that it's the backbone of treatment. You mentioned medications, whether it was NSAIDs, biologics, JAK inhibitors. Is there a role of nutrition? Patients often ask, well, should I follow an anti-inflammatory diet? Are there things any foods that I should specifically avoid? What's your recommendation to your patients when they ask about nutrition?
It's a really common question, and I think a really common experience as a human to want to have control over something, right? When you have this immune system dysregulation and you have inflammation, you want to be able to control something. And diet is one of those things that people want to engage with. Unfortunately, the literature supporting a specific diet is very sparse to none. There was a meta-analysis looking at specific dietary changes and their effect on disease activity in axial spondyloarthritis, unfortunately concluding there is no evidence to recommend any specific diet. Like you just alluded to, what I generally recommend for people is the concept of an anti-inflammatory diet, which tends to focus on fruits and vegetables, whole grains, lean meats and fish, and not as much processed food, right? So that's generally what I recommend, but there's not a lot of data to support it.
Great. In addition to physical therapy, do you recommend that your patients exercise, like do aerobic exercise? We mentioned running, other high impact activities or more low impact activities like cycling or swimming. Are those part of your recommendations as well?
Yeah, this is an interesting concept or a paradox in axial spondyloarthritis, is the idea that no activity is bad, but a lot of activity is also bad. And the data supporting this concept, which we term the Goldilocks zone of exercise. So we have animal data showing that mice in an axial spondyloarthritis model developed more syndesmophytes or more bone damage when they did a lot of exercise and less bone damage when they were suspended by their tails and did not do exercise. Now, in human beings, the evidence we have is related to occupation, where people who had blue-collar occupations tended to have more syndesmophytes than those with white-collar occupations. So we have extrapolated this somewhat to recommend lower impact physical activities. Now, that's not lower intensity, but lower impact. So on that same website I referenced previously, the NASS website, there are lists of recommended exercise activities. The general concept is recommending against things that involve high impact landing or American or European football where people are kind of smashing into each other, but rather lower impact like cycling, as you mentioned, or swimming.
Great. And is there any role in complementary medicine, things like acupuncture, Tai Chi, yoga? Could those things be of benefit to some patients?
So there is not evidence specific to axial spondyloarthritis, but there is evidence for all of those things in the treatment of chronic back pain. So I do implement or recommend those therapies for my patients who have chronic back pain, particularly once we think the inflammation has been treated. So we don't want to try to mask inflammation or treat inflammation with one of these therapies that doesn't have evidence, but we want to use them really as complementary therapies to the mainstays of physical therapy and medications.
Yeah, so that goes along to the next question that I had is, how do you follow these patients over time? How do you know that the inflammation has been controlled? Is it just based on the history, or do you ever re-image, blood work? How do you think when you start your patient on a TNF inhibitor, how do you assess whether your treatment is effective or not?
So many times it's quite obvious in that a person who has begun, for example, a TNF inhibitor comes back a couple of weeks or month later, and they've had a dramatic change to the way they feel. So they're now sleeping through the night. They're now able to do their job, seated at a desk for more than 2 hours at a time. They're able to exercise without being intensely sore the next day. So when a person comes with that history, it's pretty obvious, but I do also use an index called the BASDAI, BASDAI, which is the Bath, as in Bath, England, Ankylosing Spondylitis Disease Activity Index. This is a short questionnaire. There's a calculator online or other places where people answer questions about their symptoms in the last week. So oftentimes this is quite high before a person has begun treatment, and my general, concept is that this should improve. Now, we don't have a specific improvement metric if it gets better by 1 point or 2 points. we don't have that information to say how much improvement a person needs to have to continue on therapy, but we generally look for some improvement. And then it's also helpful to have repeat CRP values among people that had a high value initially to see that with therapy, the CRP has improved. In terms of imaging, there's a recommendation against performing repeat imaging solely for the purpose of evaluating disease activity because we think these other metrics are good enough, the questionnaire and the CRP values. Now, there was, I think, a conditional recommendation in recent guidelines to do a repeat MRI if it's going to change treatment. And so that still occasionally is something I'll recommend or ask patients to do.
Okay. And do you ever stop treatment? Let's say, your patient had a wonderful response on a TNF inhibitor. Do you ever say, well, let's either lower the dose, lower the frequency, or just stop medications? Or do you tend to continue treatment indefinitely for these patients?
So it is frustrating for many patients to recognize that this is a chronic disease. We don't have specific guidelines for when or if it is safe to stop therapy or space out therapy. This can be part of shared decision-making with individual patients who are doing quite well for some prolonged period of time, right? Typically a couple of years or more, to space out medication. And so when a patient can kind of understand the risks and in addition to the potential benefits there, I go ahead and recommend spacing it out. Now, the risk is that a person could develop a disease flare, an arthritis flare that's more difficult to control. So we think part of the immunogenicity with these medications is during periods when people are off medication. The TNF inhibitors and IL-17 inhibitors are all these large protein molecules that the immune system recognizes. And when they're not there, the immune system may generate anti-drug antibodies that inactivate the medication. So there is always a risk in spacing out med or in stopping med that the medication may not work the second time we get back on it. So when a patient can kind of express understanding of that risk, then we can go ahead and try to space things out.
Right. And do you ever have patients that are successful in stopping their medications and continue to be in remission?
Yeah, absolutely. It's not something I recommend on a routine basis with everyone, but if a person comes and says they want to do that for whatever reason, concerned about side effects or expense or whatever, then yes, there are several patients of mine who have come off medication.
Great. And one thing we haven't discussed yet is sort of disparities. You mentioned, that there's 10% of the white population carries HLA-B27. I understand that gene is much less common, for instance, in Blacks or African Americans. So does that also mean that axial spondyloarthritis is less common in these populations, or could some of these patients actually be overlooked because, they're less likely to carry that susceptibility gene?
This is a really important question and concept that I think we're grappling with within the axial spondyloarthritis research community. Historically, diagnosis has really relied quite heavily on HLA-B27 gene. We know that axial spondyloarthritis can develop through other mechanisms, so other dysregulated immune mechanisms. However, there are not very common other pathways that have been identified for which we can test. And so what I hope to see in the coming years is that we have better studies of genetics in non-Caucasian, non-European populations. So Asian populations and South American populations and Afro-Caribbean ancestry individuals to understand disease mechanisms in those groups so that we can ensure we're recognizing and diagnosing axial spondyloarthritis equitably and appropriately across all ancestral groups.
It sounds like you've mentioned that, even though it sounds like we've made a lot of progress, there's still a lot of questions that remain to be figured out. Do you know of anything that's coming down the pipeline in terms of, future treatments of axial spondyloarthritis?
Yeah, so This is an exciting field. Like much of rheumatology, we have new medications and new mechanisms of drug coming on. Every ACR meeting I go to, I learn about a new mechanism. The newest medications, as I mentioned earlier, the JAK inhibitors, in particular tofacitinib and upadacitinib. So these are expected to gain FDA and EMA, the European agency's approval. I don't know if these have fully been approved as of this today, but they're expected to be approved either shortly or they've recently been approved. We also are in need in the field of head-to-head trials, so understanding TNF inhibitors versus IL-17s versus the JAK inhibitors. And then the new mechanisms that are in the pipeline, there are two. So the first is a TYK2 inhibitor called deucravacitinib. This had a positive study in psoriatic arthritis presented at last year's ACR meeting, and we anticipate testing in axial spondyloarthritis as well. The other mechanism coming in the pipeline is MIF inhibition, and this is macrophage migration inhibitory factor. And unlike other mechanisms of medication so far, it looks like these MIF inhibitors' primary effect is through bone formation rather than the inflammation primary pathways. So it looks like these inhibit extra bone formation, and we'll look for those studies in the next couple of years. And then finally, the most intriguing treatment is ways of altering the microbiome, which is a hot topic in so many diseases. And I haven't seen a lot of consistent data supporting one way of altering the microbiome, but we may have that in coming years as well.
That's fantastic. I love thinking about the microbiome, and it's so interesting how the bacteria that live inside of us can alter our immune system, our nervous system. It's so fascinating. Certainly a lot needs to be done in that area. This is fantastic. Maureen, anything else we haven't discussed that you want the world to know about axial spondyloarthritis?
I could talk for hours, but I think we really hit the highlights.
That's awesome. I really thank you so much for your time. This has been enlightening. I certainly have a few new things that I'm going to try whenever I see my next patient coming in with back pain. And I hope that we can chat again, maybe after some of these developments have occurred, in the next few months or next year.
Well, thank you so much for the chance to talk about this.
Great. Thanks a lot. Thank you for listening, downloading, subscribing to our show, and for rating us with 5 stars, or with however many stars you think we deserve. Please tell all your BFFs and colleagues about our podcast. We'd love to hear what you thought about this podcast, as well as any other suggestions you may have. You can reach us on Twitter at ACRRheum, or through email by emailing us at podcast@rheumatology.org. You can find show notes for this episode at acronair.org. Until next time, get some exercise or physical therapy, and as always, stay healthy.